Hello, my name is Manako Epling. I'm a graduate student in the Master of Public Health program at HPU. The title of my capstone project is Increasing Adolescent Mental Health Care Access in the Freely Associated States. My project involved working with the Hawaii Pacific Area Health Education Center, or AHEC, to write a grant to submit for NIH funding. We specifically focused on the freely associated states, which include the Marshall Islands, the Federated States of Micronesia, and the Republic of Palau. The freely associated states are three sovereign states included in the Compact of Free Association with a combined population of around 180,000 residents across 800,000 square kilometers of islands. We chose to focus on this area because rural patients have reported difficulty accessing behavioral health services due to lack of providers, insurance, trust in the healthcare system, transportation, and fear of going to an easily identifiable location. Despite suicide rates being higher in children and adolescents in this area, there's no integrated policy designed specifically for this demographic. Pacific Islanders, most listed as Native Hawaiian or Pacific Islander or Asian American Pacific Islander when they're studied, have more than 15 subgroups of people with different languages and cultures. Just some key points on this slide here to provide some background. Suicide rates began to rise in 1970s with the highest rate of 28.2 per 100,000 in the 1980s. The most recent rate was 13.6 per 100,000 in 2019. More common in males and more common in youth. 60% of the victims were aged 15 to 24. A major contributing factor is intergenerational conflict and alcohol abuse, as the victim would usually get drunk, get into an argument, and then commit suicide. Although depression, anxiety, and alcohol use disorder are reportedly high, mental health seeking was low in this population. In the United States, NHPI youth are more likely to abuse drugs like heroin, cocaine, and methamphetamine, and have a greater prevalence for suicidal thoughts. Issues could arise from cultural conflict of Western individualism, contrasting with the collectivism found more commonly in Micronesian culture. Language barriers when the youth enter the American education system also puts them at higher risk of dropout and therefore substance abuse. When recommended to receive mental health services or medications, NHPI were 3 times less likely to follow through. They're also less likely to view mental illness as a serious health concern and tend to believe that they can improve on their own without intervention. And they distance themselves from individuals who report mental illness or display symptoms of depression as they view them to be potentially dangerous to others. Unfortunately, there's limited data available for incidents of mental illness and suicide in these areas due to underutilization of mental health services. All of the freely associated states are in health profession shortage areas. Palau has the most mental health providers with 23 providers total, which includes nurses, physicians, other mental health workers, and social workers. All care for the island goes through the main hospitals. Each jurisdiction has its own healthcare system, but none of them provide funding specifically set aside for mental health services, and these visits are typically referred off-island at the patient's expense. My contributions to this project were the objectives and evaluations. Our first objective is to create a scalable method for isolated countries to access mental health care that will allow for the utilization of synchronous and asynchronous mental health visits. We'll institute a telehealth advisory board comprised of key stakeholders, and they'll design a telehealth policy manual. Once this manual is created, community health centers can begin screening individuals using APA standardized questionnaires like the PHQ-9, the GAD-7, and the Kessler-6. Our second objective is to educate and inform the public about mental health with hopes to reduce stigmatizing beliefs within the community. Our third objective is to leverage existing infrastructure and partnerships with healthcare organizations to develop new methods of financing healthcare services. We'll do so by building on existing telehealth platforms that are available and collaborating with mainland child psychiatrists to provide consultations for care. Our short-term outcome by the end of the first year is for our participants to see a 5% improvement in patient questionnaire scores and changes in perceptions of mental health. For our providers, we'll see an increase in their knowledge about screening, referral, and treatment procedures and use of telehealth platforms. With this increase in knowledge of both provider and participant, we will see an increase in mental health care utilization by 5% by the end of the first year. Our long-term outcomes include improvements in reported mental health by participants, a reduction in suicide rates in the areas, and stigmas related to mental health. From a program perspective, our long-term goal is to have self-sustaining program and a staff of local community health workers and providers, which will help to provide employment opportunities. Here's my project logic model, and we based our program off the health belief theory. We'll evaluate our program by looking at both the administrative data, so referrals made, demographic reach, and provider feedback about telehealth, as well as analyzing changes on patient-reported symptoms. Limitations for the program include staffing shortages due to lack of qualified candidates, primary care team shortages, screening procedure issues with a low capture rate, language and cultural barriers, and obtaining parental consent, as our participants are going to be children. Despite limitations, if the program is successful, it could be expanded to include adults, broader specialties, and specifically veterans who suffer from PTSD and have limited access to veteran care facilities in rural areas in the Pacific. Thank you.